So I'd noticed that I was actually gaining weight, and that's not normal for me because of eating well and exercising, and so I found it really frustrating. So when I was diagnosed, it was a relief to find out that I wasn't just making things up or struggling with something for no reason. And also there was the skin and hair and different side effects like that. So it was a relief to get diagnosed with PCOS, but it was also disappointing because it also meant that there was another element that would kind of deter us having a child, which was really hard.
Polycystic ovarian syndrome is a very common condition. Depending on the studies you read, prevalence ranges from about 8 to 12% of reproductive age women. It's a very heterogeneous condition, and whilst it is slightly controversial as to how to diagnose it, the most widely accepted definition around the world is that of the Rotterdam Consensus criteria. This means that women must have 2 of the 3 of the following things. They must either have irregular or no periods and no other cause for this, typical findings on ultrasound scan, and either symptoms, that being acne, unwanted hair growth or unwanted hair loss, or signs and increased testosterone in blood tests to suggest an increased sensitivity to testosterone. Typical polycystic ovaries on ultrasound scan look bigger than normal looking ovaries and have tiny, tiny little cysts that sit around the outside of the ovary. In a normal ovary, we see the follicles being picked up and moved through the development process and dominant follicle selection. There seems to be a problem with dominant follicle selection in this condition, and that is almost certainly hormone driven. The 2 important hormones are that of testosterone and insulin. Insulin levels are high, and it's those high levels of insulin that are driving the ovary to produce the testosterone. And then testosterone and insulin come back into the ovary and cause the problem with dominant follicle selection. The insulin resistance is driven possibly by a specific polycystic ovarian syndrome factor, of which we're not sure what that is right now, and it is certainly driven by obesity and a lack of fitness. And this is why we are so keen for women who have this condition to increase their fitness and to get their BMI within a normal range.
So when I was diagnosed, I was actually put on metformin because my specialist thought that that was the best, and normally people see great results with it, and I did in terms of I was ovulating, my weight went down, my skin cleared up, and the hair gain actually came under control again. But for me the side effects were really bad, and I was really ill with it, and it compromised my quality of life quite a lot, so I had to come off it just because it wasn't sustainable. And so my GP was amazing in talking to me about following a PCOS diet and just upping my exercise, and that has been really helpful. And she said that there's been a lot of help with other women by just doing the basics like that, so that's encouraging to me.
In the women who are overweight, if we can get those women fitter and to achieve some modest weight loss, then they're far more likely to achieve spontaneous pregnancy. Pregnancy is much likely to be safer for them, and if we do need to use any fertility medication, it is much more likely for that to be effective. In women who start off in the normal weight category, or once those overweight women have these changes underway, then we can look at their medication options. Clomiphene is certainly first-line treatment for women with polycystic ovarian syndrome who are not ovulating. About 10 years ago, metformin was thought to be about equal to clomiphene in terms of effectiveness. Metformin is a tablet that you take twice a day, and it changes the insulin resistance and hence the hormone dynamics for women. As further evidence has come forward, however, it's quite clear that clomiphene is more effective at achieving ovulation and achieving pregnancy in the same period of time. If women prove to then be clomiphene and metformin resistant, then they have a choice about going on to a low-dose FSH stimulation, a type of mini IVF, ovarian diathermy or drilling, or an IVF cycle. So what is clomiphene? Well, clomiphene is a tablet that you take for 5 days at the beginning of your cycle when you have a period. Clomiphene needs quite careful monitoring, certainly needs blood tests over your cycle, and sometimes needs an ultrasound scan. Clomiphene forces the ovary to ovulate, and clomiphene is normally used for about 6 ovulatory cycles before we consider other treatment. Clomiphene is very successful. About 60% of women will achieve pregnancy over those 6 cycles, and many will be within the first 2 or 3 cycles. Ovarian diathermy is an option for women who do not become pregnant with either clomiphene or metformin. This is when, at laparoscopy, the gynecologist makes tiny, tiny little holes all over the ovary. And what this does is it encourages the ovary to ovulate. And this means for about 6 months after the treatment, women will improve fertility. Therefore, it's only useful in women who are actively trying to get pregnant. Often women will also be on clomiphene in this time, as the combination of using diathermy and clomiphene will also improve fertility over and above clomiphene alone.
At the moment, we're just about to start another round of IVF, so we're hoping that with actually doing the diet that I'm doing and getting that under control, that it will mean we'll have success and PCOS won't be a factor, which is really good.
In summary, polycystic ovarian syndrome is a very common condition, but often it is in women's hands to help themselves, and if women can become fitter and achieve a little bit of weight loss, many women will actually get pregnant before they come and see us. If we do need to use medication, it is often of a reasonably low level of invasiveness, and it is often very successful. Very few women with polycystic ovarian syndrome alone need to go on to a full-blown IVF cycle.